Thanks for listening to the Lunch and Learn with Dr. Barry, here to help educate, motivate, and put you on the right path to take control of your health through weekly discussions on topics in the medical field, public health arena, and in your community. And now your host, Dr. Barry.
Welcome to another episode of the Lunch and Learn with Dr. Barry. I'm your host, Dr. Barry Pierre, your favorite board-certified internist, founder of drbarrypierre.com, as well as Pierre Medical Consulting, helping you empower yourself for better health with the #1 podcast for patient advocacy. Today I get to bring you a special guest today, Dr. Anila Ricks-Cord, which is a good friend of mine and an expert in women's health and what she calls vagina land. She is hilarious, first of all, but she's really an expert because, of course, you guys know I'm not the biggest women's health discusser, right? Because it was a reason why I went internal medicine. But so I figured let's bring someone on who can kind of help me kind of grasp some of this knowledge that I really kind of avoided when I was a medical student and medical resident. So today we're going to be talking about endometriosis, which, depending on when you're listening to, gets its entire month of awareness. Month is actually March is Endometriosis Awareness Month. So I figured if a disease gets a whole entire month, it has to be important. And if it has to be important, let's bring an important guest on. So I'm going to just give a little bit of a bio just so you can kind of understand exactly the person we're going to be talking to. And first of all, she's hilariously funny. You're definitely going to enjoy today's episode. Dr. Anila Ricks-Cord is a wife, mother of 3 hilarious children. She's a board-certified obstetrician-gynecologist. She's a motivational speaker. She's a 2-time best-selling author. She's a media personality whose passion is to encourage women to address their healthcare concerns and fears, giving them a voice and empowering their lives, mind, body, and spirit. Again, you know the theme, empower yourself for better health here. She currently resides in Texas with her loving spouse, 3 children, and 2 lizards. She attended college at Indiana University. While there, she performed research and published articles on rats in order to help curb alcoholic behaviors in humans, which is absolutely hilarious. She did move to Baltimore to perform research and publish articles at Johns Hopkins University, this time investigating acute respiratory distress syndrome at the molecular level. She attended graduate school at Johns Hopkins in pursuit of a master's degree in biotechnology. She was accepted at the University of College Medicine. Experience significantly shaped how she practiced medicine, culminating in her receipt of the Leroy Weeks Award for outstanding clinical skills, bedside manner, and commitment to service. Again, she is absolutely amazing. And I get, again, especially for my fellas who are probably like, I'm not sure if this is a podcast I want to listen to. This is a disease process that could affect your mom, could affect your sister, could affect your cousins. So this is something you may want to listen to just to be able to kind of pass that on, right? Especially if you have a female friend or a spouse or wife or a sister who has these very vague complaints and no one seems to know what's wrong with her. And then you start kind of attributing it to maybe in her head. This is a disease process that may make you think different, right? So sit back for another great episode. Again, if you have not had a chance, make sure you subscribe to the podcast. Leave a 5-star review for the podcast so we are on the radar of everybody so everyone can be empowered for better health. So again, thank you. Let's listen to another amazing episode this week with Dr. Anila Ricks-Cord. One of the sponsors for the Lunch and Learn Community podcast is the Lunch and Learn Community Store, where you can find t-shirts, sweatshirts, coffee mugs, stickers, and wristbands with the motto, empower yourself for better health. Remember, 50% of all proceeds will go to the 5-Star Scholarship Foundation, where we give out college scholarships to deserving high school seniors across the country. Thus far, we have given out over 20 deserving scholarships to students across the country. So again, 50% of the proceeds will be blessed to the 5-Star Scholarship Foundation. And today you can get the coupon code LUNCH20. You can get 20% off your purchase, and you support these high school students across the country. Again, the Lunch and Learn Community Store is at shop.drbarrypierre.com, and the coupon code is LUNCH20. All right, Lunch and Learn Community. So you heard that amazing intro with Dr. Anila, and we're gonna, really let her speak and introduce yourself to the community. And of course, guys, I've said this before. I am not no women's health expert. One of the reasons why I went internal medicine is because I kept getting kicked out of the rooms when I was a medical student, right? So I figure if we're going to be talking about women's health, especially a disease course like endometriosis, right? Like, I figured let's get the expert to talk, and I'm just going to sit here and listen. So really, I'm actually going to be listening along with you guys, and let this expert kind of expound her knowledge on us and tell us what endometriosis is. But first and foremost, Dr. Neil, please again, thank you for coming to the Lunch and Learn with Dr. Barry.
Thank you, Dr. Barry, so much for allowing me to be able to be graced by your presence and share a little bit of knowledge.
Trust me, the feeling is all 100% mine. It's I've told the doctor and friends of mine, and I told her, I said, I'm gonna get you on the podcast. Like, you can't be giving all that amazing information out to the community on Facebook and everywhere else, and then not give it to the Lunch and Learn community. So I had already pre-warned her she would be on the show. That you did, and I am honored to be here, sir. So, Anila, for those who may not know you, may not be following you, give a little bit, outside of the bio, a little bit about yourself. Tell us why you do what you do and kind of how you got to where you're at now. Sure. So I am a board certified obstetrician-gynecologist. I'm a wife of 22 going on 23 years. Praise God, Lord willing. Oh, yes. A mother of 3 awesome kids, and I'm a 2-time best-selling author and a speaker. So through my books, my patient care, and my coaching programs, I encourage women to address their healthcare concerns and fears, giving them a voice and empowering them to live their best lives, mind, body, and spirit. So I'm originally an East Coast native. I'm the eldest of 3 children and a big, fat science geek. I openly wear that pin. I attended college at Indiana University, Purdue University at Indianapolis, and that was where I met my love and my biggest cheerleader. Performed research at Hopkins before having the privilege of attending Howard University College of Medicine, and then completed my residency at WellSpan York Health in Pennsylvania. So I was inspired to practice medicine and led to become an obstetrician-gynecologist secondary to the death of my mom. When I was 22 years old, she was misdiagnosed with the flu and subsequently died of septicemia. And for those who don't know what that is, it's essentially a bacterial infection in the blood, which basically causes massive organ failure and death. So This is why I do what it is I do. So I love it. And, thank you for sharing that story with us, because I think a lot of times people outside of, in fact, for, full disclosure, we're actually recording this on National Doctors Day. Right. And yes. I love this day because a lot of times physicians really aren't getting a lot of the fanfare and the good light that they should be getting. Right. A lot of times there's a lot of misconceptions of why we became physicians. For some reason, people think it's all about the money. I keep trying to tell you, trust me. No, sir. It most surely is not. Right. Fannie Mae, Sally Mae, whoever she is, she visits me on a regular. So, I keep trying to tell folks that. And it's really the love of wanting to, see that next person get better, right? And understanding that is, what? I wasn't there. I wasn't able to maybe make the steps I wanted to, for my mom, right? But maybe I could do it for someone else, right? And I'm totally feeling that, because I remember being a second-year medical student and getting the phone call that my father was in the hospital. And I'm a second-year medical student. I didn't even know my dad had medical problems, but that's a whole nother discussion. They don't, patient guys don't like to talk about nothing, right? And subsequently from that, he passed away. And I said, you know what? There's no way that I'm not going to, let people know, hey, not only am I a physician, but I can help you, right? From that day forth, I just kind of took that mantle. So again, thank you for, kind of taking your mantle and kind of really running with it. It is what I was called to do. I feel like knowledge is power. And Maya Angelou says, when you know better, you do better. And my goal is to make it so that people know better so they can do better. Love it. So the topic at hand today is endometriosis, and I can tell you I'll be honest, I'm an internist. I take care of patients, and I used to take care of patients outpatient, where I knew a little bit about it. But once I went inside the hospital, my knowledge of it was very, very weak, right? So I know that, again, in March, where it's actually National Endometriosis Month, right? So any disease process that gets a whole month is one that I feel like the Lunch and Learn community needs to know. Sure. So I will tell you about endometriosis. So before I can tell you what it is, allow me to describe what's normal first. Told you I'm a big fat geek, and you asked me, you know this, I'm a big fat geek. So, in women who've begun their menstrual cycles, every month the body attempts to get itself ready for the possibility of pregnancy. So I like to describe it as your brain calls your ovaries and says, hey girl, we're trying to get pregnant this month.
Under the influence of your brain, your ovaries make estrogen and progesterone, which causes the lining of your uterus to get nice and thick and fluffy, and it causes you to ovulate. And so the thickness of this lining, this thing happens every single month, where every month we get nice and thick and fluffy, so that if we actually do get pregnant, there's a nice nourishing space for a fertilized egg to implant and grow. If you don't get pregnant, that lining dies and peels off, and that peeled lining is actually your menstrual blood. And so if you don't get pregnant, it starts all over again. Better luck next month. Maybe it'll work out next month. So here's
Better
the
luck
catch.
next month.
Exactly. So just like we bleed out of our uteruses and out of our vaginas and onto whatever, products it is you use, there's also something called the theory of retrograde flow, where we actually bleed backwards too. So if you imagine that this uterus has got this cavity on the inside, and whenever you talked about my lives, whenever I do them, I use my face as the uterus, and then I take my locks and I separate them and pull them off to the side so you can see that those are fallopian tubes, and my fist goes underneath as an ovary. You bleed backwards into the uterus, or actually from the uterus into the fallopian tubes and into the pelvis. Now, this is where it's an issue. In some of us, that tissue, that lining, that is this endometrial lining that's supposed to regenerate itself every month, some of that tissue takes residence actually in your pelvis and in your abdomen. And so come next cycle, the tissue does what it does, and it thickens to try and make a lining where it is, but it's in the wrong place.
The wrong spot.
And so
where it normally
yes,
does is in the uterus.
exactly.
Wow.
Right.
Okay.
Right. So you got this out of bounds bleeding going on, which triggers inflammation, kind of like if you hit your elbow, you hit your knee, and it swells up right nice and it's sore. Your body responds to this perceived injury, and your immune system kicks in and gets involved. And this is where scarring happens. So what is endometriosis? It's when you have your period in places other than in your uterus. And these endometrial cells, once they get access to your pelvis, they can then travel to other places and get access to your blood vessels and your lymph system and go outside your pelvis to other places. So it is primarily a disease of your pelvis, but because they don't have any limitations and they know no bounds, they can go other places too.
So once that retrograde bleeding happens, it's really like all fair in love and war, pretty much.
Yes, for some of us, we all do it. Not all of us. We all have this retrograde flow, but not all of us have tissue that are like boundaries. I don't know no stinking boundaries. I'm going to be where I want to. And so there's a thought that there's a genetic predisposition where there's a subset of people who have tissue that decides, oh yeah, I'm going to be ectopic. I'm going to go wherever it is I want to go. I'm maybe it's like living in a large city. You need to get to some place that's not so highly populated. So you decide there's not so many people there. Let's grow into pelvis. So the actual prevalence of endometriosis is not exactly known. So they say that you see it in between 25 to 38% of adolescents that have chronic pelvic pain, and in 10 to 15% of women that are reproductive age. And so there's a subset. So we talk about this theory of retrograde flow, and then there's also a thought process too. I told you, big fat geek moment. I apologize. I'll throw up disclaimers when I come in.
Oh yes.
So
trust me, we're all here for this. I'm sitting there, I'm listening. I'm like, okay, all right.
Cool beans. So from an embryologic perspective, I know you remember, you'd have tucked it back in a Rolodex somewhere because it doesn't serve you anymore. But for those of us who are women, when we actually go about being formed in our mother's wombs, we have got a fallopian tube and a uterus, and another fallopian tube and a uterus. And what happens is these two halves come together to make a whole. The center hollows out, and you've got, if you're lucky, you have one normal functional cavity. There's a subset of people who have what are called Mullerian anomalies, where the two little pieces of uterus don't get together the way they're supposed to. It doesn't hollow out in the center and become one. And so these people are also a setup for endometriosis because they have ectopic endometrial tissue that ends up in other places. And so about 40% of these children that have these genital tract defects will have issues with endometriosis. They say 50% of women that have infertility have endometriosis, and 70% of women and adolescents that have pelvic pain actually have endometriosis.
Wow. And because we don't know the true figures, do you feel like the figures may be higher than what we're even picking up?
I would say so, because unfortunately it takes about 9 years to diagnose endometriosis because it's a disease of exclusion. And so when people present, so you have a patient that will come and see you and they've got these vague multitude of symptoms. So like in women, in grownups, people who are not adolescents, and adolescents are defined as 10 to 19 years old. So in reproductive age women, you could have a lady that comes to see you with a complaint of pelvic pain, either with her periods or with sex. And so if it's pelvic pain pain with her period, we call it dysmenorrhea, which is this dull, crampy pelvic pain that might start about 2 days before your cycle starts, last the entire length of the cycle, might occur a couple of days afterwards. Or if it's chronic, where it's been present for more than 6 months, it can be dull or throbbing or sharp. Or even in one of my patients, she has a burning sensation. Every month when her cycle shows up, she's got a spot in her left lower quadrant on her anterior abdominal wall where it's like a hot poker. That's how hers makes itself manifest. She has pain all the time, but when her period shows up, it just burns in this one little spot. So that's with cycle. You have pain with your period. If you have pain with sex, you will have patients that have complaints of pain with penetration, particularly deep penetration. And so when you go see your OBGYN, one of the ways that you can kind of mimic this is, the thought is, when you get these endometrial implants inside your personal space, you can get these, it starts off as a microscopic disease and you can get nodules. Our uterus has got this support system inside our pelvis. It's kind of like, for ladies who wear bras, it's kind of like the bra straps. You got these things called uterosacles that support it on the inside of your pelvis. You can take your fingers in a lady who has endometriosis, put them in the back part of her vagina, separate them like the peace sign, and stroke, and practically make her leap off the table because she has nodular implants in the back. And so you can simulate this pain with sex when you stroke on these uterosacles in the back if she's got nodules implanted inside them. Ladies who present with infertility. And so infertility technically is defined as a chick that's less than 35 years old that's been trying for a year to has been having regular sex for a year and trying to get pregnant, hasn't. If you're over 35, is 6 months essentially. But they say that 30 to 50% of women who have infertility have endometriosis. If you have a lady that presents and she has an incidental finding on ultrasound, when she's got some pain, you do an ultrasound, she's got a mass on her ovaries, there's a particular endometrial implants can actually implant anywhere inside your pelvis, on your bowel, on your bladder, inside the wall of the uterus too, and I'll come back to that one, and inside the ovary. You can get what are called endometriomas, where when you look at them on ultrasound, they are essentially the equivalent of blood clots inside the ovary. A lady that's got an ovarian mass that is an endometrioma, you have a high index of suspicion that she has endometriosis. Wow. It'll also present in ladies that have bladder issues, like if you have a feeling like where you do not have a UTI, but you feel like you're going to the bathroom all the time, or you feel like you got to go right now, or you have pain when you go to the bathroom, that could be a sign of endometrial implants in your bladder. If you have bowel issues, where you have issues with diarrhea or waxing and waning diarrhea and constipation, or pain when you defecate, or colicky bowel, that can be a sign of endometrial implants in your bowel. There is a version of endometriosis called adenomyosis, which is what actually Gabrielle Union had. Heavy menstrual bleeding is a possible sign of endometriosis. And by heavy menstrual bleeding, allow me to clarify. A regular period is supposed to be no more than 80 cc's. So in simple terms and in English, 80 cc's.
Talk to the men out here, because the men
right, right. I'm about to tell you. So a normal period is 4 hotel bottles of lotion. Okay. It's 2.7 fluid ounces, or it's about a third cup, that mixing cup that you have in the kitchen when you're making stuff, a 1/3 cup size. That's 80 cc's. Anybody who has more than that, and some of the patients that I have had heavy menstrual bleeding, they making crosses and skis and they underpants with pads. They got multiple 2-3 stacking them like mattresses. Wow. Or they use tampons. If you can use a Super Plus tampon and that thing falls out in an hour or two, you have heavy menstrual bleeding. For Gabrielle Union, when she was talking about her fertility struggles, what she suggested was that she presented to her doctor with heavy menstrual bleeding, and they traditionally put her on OCPs, birth control pills, in order to be able to regulate her flow. She subsequently was found, after having her struggles with fertility. So she had gone through some IVF cycles. She got pregnant she got pregnant more than a couple of times. I think she suggested maybe 9 times she got pregnant, something along those lines, 7 to 9 times. But with her, she has endometriosis in the walls of her uterus. And so you got this glandular tissue that's supposed to do right and be nice and fluffy like a comforter in the wintertime for this egg that's going to fertilize in the wall, but it has a place where it's supposed to be. It's only supposed to be on the lining of the inside of this uterus, not deep within the muscle. For people who have the endometriosis inside the wall of their uterus, or the adenomyosis, they actually have bleeding that occurs within the muscle itself. And this leads to inflammation and issues with fertilization and implantation and being able to carry pregnancy. So again, heavy menstrual bleeding is also a sign, as well as irregular menstrual bleeding. Endometriosis can also make itself manifest in the form of low back pain or chronic fatigue. This is why it's so nondescript and it takes forever to diagnose.
So
and
that's
that's
what
in
it takes
women.
about. That's why you said 9 years.
9 years, yeah. In adolescents, which is that group between ages 10 to 19, and there have been some documented cases of little girls who didn't have those Mullerian anomalies I talked about, where your uterus didn't come together right. There have been babies that have been documented to have endometriosis as young as 8.5 years old. Those little girls will have symptoms that can be cyclic, like only occurring with your pain and not having anything to do with your period, but they can get pain that gets worsening and more severe when they actually start having periods. They can have rectal pain, they can have constipation, they can have pain with defecation when they go to the bathroom associated with their cycle, rectal bleeding, pain with urination, and even blood in the urine or that need to go right now. And so it's so nondescript. You can see how a physician would run through a litany of tests before finally getting to the point where you even considered endometriosis at all.
Now, 9 years seems so long. It is. Should it not be like more ahead of the line, or do you really have to kind of rule out some big stuff first before you can say like, okay, let's think about endometriosis since I've done, cross my T's with everything else.
So I think that because it was a diagnosis of exclusion for the longest time, to truly diagnose it, you need a tissue sample. And so the thought process.
So how you get tissue if it's in the muscle? How you get, wow, okay.
Right. And adenomyosis you only get if you have a uterus in the path lab. That's how you diagnose that. Otherwise, it is, I take you to the operating room. I do a diagnostic laparoscopy where I poke a hole inside your belly button, fill you up with carbon dioxide, poke another 2 holes inside your belly in order to be able to get a camera inside there and some graspers to move around and look to see if I can see signs of disease. And it's got 4 stages to it. You could have minimal disease, which is microscopic and you don't see nothing, to stage 4 disease where you have everything stuck like Chuck on the inside. But ideally, if you get to the point where you have to do laparoscopy, then you go inside and you biopsy different parts of the pelvic sidewall, underneath the uterus sacrals, if it's on the ovary, wherever you see, there'll be, sometimes it looks chocolate, sometimes it looks white. And so any abnormalities you see, you're biopsying them in order to be able to confirm the presence of disease. And that's part of it. A lot of us who are conservative would want to try, I think old school thought was, if you have endometriosis, let me try all these other things to make sure it's not that before I use last resort and take you to the operating room.
Which is the operating room.
Right. And poke a hole in your belly in order to
you start talking operating with some people and they're like, whoa, you want to do what? Just a look?
Exactly. And yes, just to look. And then you think about the fact that anytime you poke a hole inside anybody, anytime you perform surgery, there's a risk of adhesive disease thereafter. And so it's a risk versus benefits kind of thing. But I think that the thought process, more people are becoming more aware about how much of a big deal this is, because you think about how often when you were seeing patients that were women, you joke that you got put out of the room all the time, right. but it's a comfort level that's got to exist between you and your physician. And I'm sure you've seen the commercials talking about the meds and the studies that have had endometriosis, where people don't feel comfortable talking about what's going on with their period, how much they bleed. Like, you'd be surprised the number of women that have got menorrhagia or heavy menstrual bleeding where they can practically write their name on the floor in blood in cursive every time their period shows up, and they think it's normal, and they're not asking anybody about anything.
Wow.
And so
have you had trouble in the past, like trying to even pull that type of information out of your patients?
I think for me, I'm fortunate in that I laugh and joke with my patients. And then because I have also had issues with menorrhagia, Black people are real good at making fibroids. Sidebar, I have a fibroid uterus that's about the size of a 12-week pregnancy. And as a consequence, I think God has got a funny sense of humor, because as an OBGYN, there's so many things that I have experienced that I can relate to with my patients. And having been one of those chicks that has menorrhagia not that people want to know what my contraceptive option is, but I use a Mirena IUD in order to control my menorrhagia. Without my Mirena IUD, I can use a Super Plus tampon and it falls out every 2 hours, and I could write my name on the floor in blood and cursive. Like, using a regular tampon, before my Mirena, I didn't know what that was.
Wow.
And so I use humor in order to bridge the gap, in order to be able to ask those kinds of questions. So tell me about your menstrual cycle. How long does it last? What products do you use? How often do you change them? Because a large number of these people who should have hemoglobin hematocrits of like 6 with their eyeballs rolling back because they bleed so much, they think that's absolutely normal. They think it's absolutely normal. And then because it's your period and you're not comfortable talking about that stuff anyway, you're not going, it's a don't ask, don't tell. unless you have the kind of relationship with your physician where you feel like you can talk about it.
You can talk about it. And if you can't, honestly, you can't, if the relationship isn't there to talk to with your OB, you definitely not talking to the hospitalist, right? You definitely not.
Of course not. If the person who sees your soul from the bottom, you can't have that conversation. Why are you talking to people who just see you with clothes on? Exactly.
Right.
Exactly.
Oh, okay. Oh, all right. So see, Lunch and Learn community. I told y'all we was gonna get some learning today. Like I already let y'all know we're gonna do some learning today. Because again, I'm taking notes right along with y'all because again, I've experienced and I've taken care of patients with this disorder. But of course, you know me, I'm referring you out to the OB when I boom, I think is what you got. Go ahead, see my OB friend, see if that's the case. So definitely, wow, okay. So what about, so we talked about, I hear some of, some of the signs and symptoms kind of really associated with it. Mm-hmm. Now, is there anything that these patients are doing that may have attributed to getting endometriosis? I mean, because I guess they have to have a menstrual cycle, right? So it's not all about the retrograde bleeding, but is there
Well, in theory, remember, there are some babies at 8.5 that haven't had periods that have issues that have documented endometriosis.
Wow.
The vast majority of us have menstrual cycle related signs and symptoms where we're cycling and we've got this retrograde flow, but you don't necessarily have to have a period. You can have these girls so when you talk about risk factors for endometriosis, we talked again about the developmental conditions that predispose you to basically having your belly peppered with endometrial tissue. We talked also about the fact that there are some people who are believed to have a genetic predisposition. So if you have a first degree relative that has endometriosis, and by first degree relative, it's either your mama, your sister, or your children. If you have a first degree relative that has endometriosis, you have an increased likelihood of having it too. And there's a thought process that in these people who have a genetic predisposition for endometriosis, there's something about the way their cells signal that they don't respect boundaries and go from one place to another. Like, you're a schmooterist. I'm going to the pelvis. That's who I am.
I'm going wherever I want to go. You can't tell me nothing.
Exactly. And then there's also a thought too that if you started your period early, like 10 or less, that you're at increased risk for endometriosis.
Wow. Okay. All right.
And then it unfortunately has awful side effects too. Awful side effects.
Now, especially because we kind of lean on the kind of starting the period early. So of course, we're talking about like kids, and then obviously this is an issue that adults deal with as well. But I'm always kind of fascinated, especially as I'm an internist, so I really only see 18 and up. As OB, you're seeing all kinds of ranges. Do the complications associated with it, like, are they much worse off in the child than adult, or is it still kind of like it's bad either way? Like, we know the rectal bleeding, we know the urinating, we know all this, but like if you had to, I guess, choose, right? Like, when would you rather start dealing with these problems? Would you rather deal with it as, in the younger age, or more of that older, 35, 40?
Well, and that's interesting. Thank you for reminding me. I forgot about that one. I'm going to tell you a little sidebar about that one. So in theory with children, the thought process is, again, 40% of adolescents with genital tract anomalies, 50% of them have issues with infertility, and 70% of women and adolescents with pelvic pain have got it. But the thought is that you've got longer in order to be able to pepper your belly with these things. And so as a child, outside of the symptoms that we discussed beforehand, the issue is, think about all the years, particularly undiagnosed, that you've got your belly, your abdomen and your pelvis, your bowel, your bladder being peppered by these implants inside your personal space that then may not reflect or respect boundaries, hop a ride on your vasculature or in your lymph system and go to other places. You can actually have endometriosis implants in your chest. So,
like the chest wall?
Yes. Yeah. Wow. You can actually, it's this thing with, so, cells and how they're supposed to respect boundaries and go to confluence and only move by protein signaling. Endometriotic implants can end up inside your lungs. You can actually get a collapsed lung as a consequence of endometrial implants. You can actually have hemoptysis, where you cough blood, for people who don't know what that is. Yes. Or you can actually have, what is the other one? There's the collapsed lung, there's coughing up of blood, and there's one other. I'm going to circle back. When you talked about the difference between adults and children from the standpoint of what it is they have, you think about, you have longer to be able to develop the side effects, which are infertility and adhesive disease, which distorts the tubes and the ovaries. You have inflammation, which is going to cause scarring, and you've got pain. And so you've got a longer time in order to be able to do this. So
Wow.
it can give you chest pain, collapsed blood in the lungs, and coughing up of blood. And then also with endometriosis, which I'm a sidebar, in people who don't have it, when you talked about the difference between adult versus children, you can be a perfectly normal lady who went to go have a C-section. And as a consequence of having a C-section, because the uterine lining was disrupted, you can get endometrial implants anywhere along that incision line. So when I do C-sections, so we cut through the skin, we cut through the fat, we cut through the fascia, separate the muscles, so our organs are all lined with this peritoneum. It's got its own sausage casing. Your bladder sits on top of your uterus, and there's this thing called the vesicular uterine peritoneum that you cut. You push the bladder out of the way, you cut inside the uterus, you deliver the human, you close the uterus in one layer, and then fold it back on itself. You can get endometrial implants from the opening of that uterus being out in the abdomen, in the fascia, in the anterior abdominal wall, and in the incision site. In my residency program, we had a lady who had a complaint of pain every single time her period showed up. And actually, when we imaged her, you found what looked like a small little 1 centimeter hole, that it was actually much larger when you got inside her and started dissecting out, where the endometrial lining had implanted in her incision. And every single time she had a period, it would bleed in her anterior wall in that incision site.
Wow.
I had a lady who, when she was a child, she had, I can't remember what her particular condition was. She had some kind of condition where she ended up having anomalies with her legs. One was rotated backwards. The other was rotated in a strange way. And so she ended up having to have one of them amputated and was compromised. Actually, she had both of them amputated, bilateral amputee. And there was something going on with her belly where she had some kind of surgery, or maybe there was a shunt or something that was placed. She presented with a complaint of belly button pain at one point in time. And on further inquiry, when you talked to her, she said that she could milk her belly button around the time when her period showed up and get a brown discharge to come out. And sure enough, she had endometrial implants in her belly wall, where when she started cycling, because she had had surgery when she was a child, it was enough to disrupt stuff. And literally, she bled through her anterior wall, where there was a defect in the wall where the implants would bleed right inside there. She got a little knot that was inside there.
Wow.
Another chick who came to office, same kind of thing, complaint of just belly wall pain. She had an endometrioma in her anterior wall as well. And so you go to the treatment modalities for endometriosis, because she's got endometriosis. It's not inside her uterus. It's endometrial tissue someplace else. So, and then outside of what it does from the standpoint of being a child and you having all this time to pepper your belly, and being able to get it, being a normal chick who just had a C-section or a disruption in the lining of the uterus, and now you have it, it causes all kinds of pregnancy complications. It causes miscarriage, increased risk for ectopic pregnancy. You can get bleeding during pregnancy and hemorrhage afterwards. It sets you up for preeclampsia. You can have a placenta previa, where ideally placement of the placenta is hanging from the top of the uterus like a chandelier. It increases your risk for a previa, where it covers the opening of your cervix and sets you up for a C-section, sets you up for preterm labor and delivery, a C-section, and low birth weight babies. So it's just all unpleasant.
This is just problems.
Right.
Wow. Okay.
And the thought is that because you have got these ectopic implants, this endometrial tissue inside your pelvis that then triggers an inflammatory response, as women, when we get pregnant, so we have relations, the sperm travels up our vagina, through our cervix, through our uterus, out our fallopian tube to find the egg, fertilizes the egg, and then the fallopian tube pulls the egg that's fertilized towards itself. And then in the tube, you've got these hairs, these cilia that kind of push the egg through the tube and into the wall of the uterus. It is a thought process that with people who have endometriosis, that the inflammatory mediators or chemicals in their pelvis are so high that it's toxic to sperm. And that's part of the compromise with your fertility too, that the sperm get inside there and go because it's just not nice for them to be there.
This not the place for me.
Right. No, I can't work up in these conditions. I cannot be up in here. No.
Wow.
Yeah. So it's crazy.
That's and well, I guess the question is like especially in your stance, like what's the likelihood that you're gonna see a young girl who's complaining of a lot of these issues and say, you know what, let's open you up and see, right? Like let's do a laparotomy, right? Like does that also aid into it as well, that maybe the surgeons aren't likely to open them up to check because they're like, I don't want to put a surgeon, I don't want to put a kid through that.
And you think about the fact that if it's a child, Some of us are comfortable with adolescents, some of us are not. There's a branch of gynecology that is specific to pediatrics. And so you think about access and you think about whether or not people are even listening to what the complaints are. How many people with a child who complains of having constipation would ever think that it's endometriosis and not you just eat too much junk or you need to drink some more water? I think that there's such vague complaints that unless the child has been complaining about them the entire time and you've done a complete workup, and I can't tell you the number of times where with endometriosis, it comes down to the gastroenterologist and the OBGYN. They've been sent in order to be able to get a colonoscopy, in order to be able to be assessed to see what's going on with this presumed abdominal pain that once they rule them out, that it's not GI in origin, then it becomes, well, the only other thing you got left down there is your reproductive organ. So it's either your gut or your uterus, which is it, or the attachments to it.
Whew. I'm scared. I'm scared for y'all because I don't have to deal with those issues, but and clearly this is why a disease process like this needs this whole month, right? Because if it averages 9 years to like that shit, we got to move this up, right? We got to move this up quickly. That should not be the case. I'm so sorry for y'all. I'm so sorry for y'all.
But I think things are getting better. Again, we used to treat it like it was a zebra, and you go through everything before you. And even from the standpoint of you ask about what's the likelihood of somebody performing surgery. So ideally, the thought is to do laparoscopic surgery, but you think about people who manage conservatively, they would put you on everything first.
Exactly.
Birth control in order to be able to shut you down to see what could exactly. You would go through all the other conservative options before definitively going to surgery. And the data suggests that even if you do surgery alone and that's it, because there are people who definitively get relief with surgery, particularly if you have adhesions where you imagine that you've got, what's a good example of an adhesion? Where you have an abnormal connection of one thing to another. Maybe like imagine a ribbon, not inside your uterus, but still, if you had a connection between your uterus and your bowel, or your uterus was stuck to your anterior abdominal wall because this inflammation causes this scarring and this adhesive disease to take place. If you underwent surgery,
almost like a fly trap, where it's stuck to that is shit.
That's a good analogy. Yes, thank you. Minus the dead flies. Yes.
Minus the dead flies. Yes.
Minus the dead flies. Yes, exactly. Where you have things sticking from one point to another, and it causes, for the people who have chronic pelvic pain and have advanced disease, just going to the bathroom causes them problems. If they have issues with constipation and their bowel is stuck to their anterior abdominal wall or stuck to their uterus or contorted in some way, shape, or form, and you think about how the bowel has got this motion where it kind of squeezes fecal matter from one point to another, just being constipated is enough to cause you wicked pain. And so people who have chronic pelvic pain secondary to adhesive disease, secondary to endometriosis, have to do things to alter their lifestyle, like to make it so the consistency of their stool is more like soft serve, so the bowel doesn't get over distended and piss it off and cause pain.
Wow. So we didn't scare the lunch learning community enough. But Dr. Anila, they want to hear now, like, all right, Dr. Anila, like you don't scared us. We believe you. We know this is an issue. Please tell me how to treat it, or at least prevent it, right? Because it is. Sure. I guess that's a two-part question, right? Yes. Is this a way, right? Again, if little kids is getting even before they're menstruating, right? Is there an actual way that you could do anything about this? And if there is, like, how do I treat it? Like, I know we mentioned a little bit about the oral contraceptives, which again, I'm an internist. I don't know none of those things.
Oh, that's hilarious. You said, so I'm trying to be really, really good, but all I can hear you say is, I leave that to the people in vagina land. Nope, I don't do that. So treatment options and prevention. Unfortunately, at this point, because we understand its mechanism of action, but we don't really understand what causes it. So because we don't really understand what causes it, we've seen, there are clusters of people that look like this and clusters of people that look like that. We don't know how to prevent it. And so the thought now is, with treatment options, there are a couple. The thought ideally is you want to decrease your inflammation. And initially, incidentally, I didn't mean to scare anyone. I just, knowledge is power. I wasn't trying to scare anybody at all.
Lunch learning community knows that, we're going to talk about a lot of disease courses that, if it's not taken care of, it can cause a lot of problems.
Yes.
You can't take care of the problem if you don't know that the problem is out there.
This is true. You're absolutely correct. And so with treatment, so ideally first line is non-steroidal anti-inflammatories. ibuprofen and naproxen. Back in the day, we used to give people for chronic pelvic pain narcotics, and unfortunately, we turned them into crackheads. Yep. So ideally, the goal is to stay away from opioids. You want to do what you can do to decrease inflammation. That's first line. Mm-hmm. Second is you use hormones. So you either have a couple of choices. You can either use birth control for non-birth control reasons, if you're not sexually active and you just have wicked pain, or you get a twofer trying to decrease your pain and make it so that you don't get any unplanned babies. The thought is you can use birth control pills, you can use injectables, which would be Depo, you can use the implant, which is a Nexplanon, the ring. You either use them continuously, where you get on a method and you stay on a method, or you use it cyclically in order to be able to make it.
From a non OB, let's say, I'll even talk about from the guy's perspective, right? When y'all take these birth control pills, is it so that y'all will bleed less, or so y'all won't?
So yes. Okay, got you. Yes, thank you for asking me for clarity. Yes. Well, in my case, as I told you, I can write my name on the floor in blood and cursive. Mine is definitely about not having humans and bleeding less. And so earlier when we talked before about how the brain calls the ovaries and tells the ovaries we're trying to have a baby, and the ovaries go about thickening up the lining of the uterus and making it so you ovulate. Your body doesn't care how the hormones are made. You can either make them or take them. Your body just wants them to be present. And so the thought with the use of birth control pills or contraception, depending on which kind you use, is to thin the lining of the uterus so you don't have a nice fluffy lining for the egg to implant. And some of the modalities actually shut your ovaries down so you don't ovulate. In this case, the goal is to be able to thin the lining of that uterus. And if you're using it continuously, to shut down those ovaries so that you don't have that tissue that's in other places that's getting nice and thick. And then after it gets nice and thick, it dies and you've got all this inflammation. You're trying to stop that process. Just shut it down. Thank you very much. Where you're in these other locations, yes, where you're living, where you've traveled abroad.
We trying to starve those areas off. And
that is exactly right.
We got to take.
Right.
Okay. All right. See. All right, guys. Trust me, guys. I got y'all on here. I know this is a women's health forum, but trust me, I'm here.
So from the standpoint of endometriosis, the goal is to starve that estrogen-sensitive tissue that's sitting out there in the periphery. So you can either use hormones in the form of birth control, or there's another batch of medicines you can use called GnRH agonists. I'm not going to have a big fat geek moment over this because it's too much. But old school, there was a medicine called Lupron, which was a shot that you could get. New school is this one that you've seen on TV called Oralista. They're both GnRH agonists, and what they do is they cause the equivalent of a medical menopause. They shut you down, allow the implants to starve and die, but they can only be used short term. Like the Oralista, depending on what your symptoms are, you can only use it 6 months to 24 months. And the same with Lupron, because there's some side effects that go with it. Because it puts you into a medical menopause, it can actually decrease your bone mineral density and make you like a little old lady that snap crackle pop with your bones. Exactly.
Wow. Okay.
Exactly. So those are treatments. And if you do hormones, the thought is if you do hormones, you do NSAIDs too. So hormones and NSAIDs. And the goal if you use the hormones from the standpoint of the contraception, the goal is to trick your body into this sort of false pregnancy state, shut down your ovaries and make the implants die or go into a coma and decrease that inflammation. The next option would be surgery, like we talked about, laparoscopic surgery, where you fill the belly up with carbon dioxide, drop a camera on the inside, put in some graspers in order to move things around. See if you can find some tissue to biopsy to confirm the diagnosis. If there are adhesions, you disconnect those adhesions. And then if there are lesions that you can see, you do what's called ablation. You literally go and you burn these adhesions on the inside of the belly. Now, the lovely thing about surgery, but the bad thing about surgery is that anytime you have surgery, God makes all of our organs have their own organ case to them. Even your belly, it's got a lining just like the inside of your mouth. Anytime you pop inside somebody's belly, you risk the possibility of causing them adhesions as a consequence of the surgery. And if you do surgery alone, how it
happens with the C-section, where
yes. Well, the endometriosis actually tracks. So all of these layers that you put together, it actually tracks into all these. So imagine anywhere your knife touched, skin, fat, fascia, peritoneum. The endometrial cells can be in any of that line from the inside of the uterus all the way out, from the incision site in the uterus to the peritoneum, to the fascia, in the muscle wall, in the fat all the way through in the skin itself, all the way through. And the lady I was talking about in residency, she had a tiny little lesion in her skin. But when you went to go dissect this thing out, it was huge and it was in her fascia. So it was like a mountaintop. You just saw the top of the mountain. And when you got up underneath the surface of her flesh, you saw the rest of this mountain down inside. They were like icebergs, that analogy they used.
I'm not gonna lie. I might not wish endometriosis on my enemy. I don't know. The stuff I'm hearing.
It is not a pretty thing to have at all. And the problem with surgery is that if you just do surgery within a year, you got symptoms that return again.
Wow.
Definitive treatment for endometriosis, once you have done having your baby. So ideally for ladies who are reproductive age, the goal is to shut you down till you're ready to get pregnant. You get pregnant, then we shut you back down again. And then when you're done, depending on the severity of your disease process, some people respond well to hormones, some people don't. And definitive treatment for endometriosis is removing your uterus, tubes, and ovaries, being without hormone for a period of time to allow the implants to die off, and then restarting the hormones afterwards, because you really need to be on hormones till menopause up in this country, and the average age is 52. Otherwise, you look like a man about your blood vessels and you snap, crackle, pop, and all kinds of other stuff. So outside of that, there's a thought process that there are some alternative medicine options that may or may not work. Now, the traditional data says it doesn't work, but you have to bear in mind that we are unique individuals. We have bio-individuality. And so what works for one person may not work for somebody else, but may work for the person that's using it. So the thought is that acupuncture, herbal remedies, and homeopathy may very work for some people. Okay. Outside of that, from the standpoint of, you asked if there's anything you can do to prevent it. No. The thought process is to try and make yourself as healthy as you can be and to have coping mechanisms for the pain. So exercise.
Healthy wise, you're talking about food? Or?
Right. Okay. Yeah, we're talking about food. We're talking about eating a balanced diet with very little processed food in it. We're talking about getting enough sleep because you heal yourself when you sleep at night. We're talking about exercise in order to be able to decrease inflammation, and meditation in order to be able to help cope with the pain. There's also in the data, there's a suggestion too that people who have endometriosis are deficient in vitamin D. And so when we talk about how this tissue responds and how it can say, oh, you have to stay at the curb, but I'm going to go outside the boundaries and do other stuff. In these people who have endometriosis and are found to have vitamin D deficiencies, folks believe that supplementation of vitamin D might make a difference. And any woman who's of reproductive age needs 800 international units of vitamin D a day anyway. Some of us brown people don't spend a whole lot of time in the sun and don't generate the vitamin D. And I'll give you an example. A lot of people who drink milk, they get milk and eat cheese, 8-ounce glass of milk and eat cheese. They get all the calcium and vitamin D they need. I don't drink milk because I'm lactose intolerant. The last time I had my labs on, I'll tell you, my vitamin D level was 17. I'm surprised Dr. Berry ain't laughing at me. Normal is considered to be 30. And in vagina land, as an OBGYN, we like it to be around 60. And so vitamin D supplementation, outside of finding that people who have endometriosis are deficient in vitamin D, there's also a thought process that vitamin D and depression have a role, deficiencies in vitamin D, and colon cancer. There are deficiencies in vitamin D. So just bone up, get on your vitamin D.
Get on the vitamin D. Whew.
Yes.
All right. Whew. All right. I'm scared. It's like I said again. I kind of scoffed at first. 'Cause I was like, "Why does this little thing have its own mouth? Like this ain't heart disease. This ain't But like, okay, all right,
it's not, but
it deserves it.
It affects your quality of life. So you talked about seriousness of disease. The reality is that endometriosis isn't going to kill anybody at all. There's a thought process that when I talked earlier about the ovarian masses that you can get, the endometriomas, the endometrial tissue that invades into the ovary and actually takes residence can actually give you. So with ladies who have, sidebar, I'm making a correlation. I apologize for the running, but I'm coming back. Ladies who have polycystic ovarian syndrome, who don't have regular menstrual cycles, are at increased risk for endometrial cancer because that lining can become atypical. They find that same kind of thing can happen in the ovary, where the endometrial tissue that is implanted in the ovary and has now caused this chocolate cyst full of blood, which is an endometrioma, it can take on abnormal qualities just like the lining of the uterus when it is atypical in ladies who have PCOS. They haven't found where it's actually become full-on cancer, but it has the capability to change because it's endometrial tissue outside the uterus doing some crazy stuff.
Doing some stuff.
Right. The bad thing about endometriosis is, like I said, if you have it, it's everything, unfortunately. It can cause infertility. It can dictate whether or not you can leave your house and function without pain. The patients that I have had chronic pelvic pain secondary to endometriosis sometimes have to be selective about the kind of jobs that they take. Because if you have a pain syndrome that's present, say 21 days out of the month, where you might have 8 out of 10 pain on most days, but maybe you get a break, and on some other days you've got 5 out of 10 pain. It interferes with your ability to be able to live. If you can't get out of bed and get up and get functioning because your belly feels like it's demonically possessed and it's telling you all kinds of things from a pain standpoint, and you can't function pain-wise, then how can you hold a decent job? There are people who, because they have issues with endometriosis and the pelvic pain is exacerbated when they have relations. If you are single and not already in an intimate relationship, you have a difficulty with engaging in relationships. And if you're married, it can interfere with your ability to be able to have an intimate relationship with your spouse. And then that over time leads to depression because it's a chronic pain syndrome. Intimacy is a huge part of having relations, or we're having a relationship. And imagine not being able to be intimately associated with the person that you vowed to spend the rest of your life with because it hurts so bad you can't stand it. That It's like having nails pounded in the back of your personal space. And so you'd much rather eat a nail than have an intimate relationship.
Wow. Oh, Lord. Okay. All right. You win endometriosis, sis. Dr. Neil, before we let you go, right? I got definitely a couple more questions, but just more on a lighter note, right? Because endometriosis has scared us. Again, I might have to tell my residents, like, hey, like that patient who comes in for this vague abdominal pain, like, we might need to move it up a couple notches on the differential now. Can you talk about how what you do, right, can help women, take better control of life, and not necessarily just for endometriosis, but just in general, right? And this is a question I like to ask. I just want to, I want to kind of get my guests' thoughts on, like, what do they do to help people empower, especially in your world, women empower themselves for better health?
Sure. So what I like to do with all of my encounters, be it individually as a patient, either in the hospital or in coaching, or when I was in private practice, is I encourage them to be their own healthcare advocate. When you're looking for a physician, the purpose is to find somebody that you can partner with the ultimate goal of optimizing your health. Medicine is no different than customer service. It actually is like customer service.
Yes, definitely.
Service. So for women, for those of us who like to drop some coins every now and then in places like, say, Nordstrom, we know that Nordstrom is pricey as all get out. But the one thing that you can bank on with Nordstrom is they have customer service on lock. They're rumored to have taken back a tire from somebody who said that they bought it there, even though they don't sell tires. Medicine is no different than that. If you don't have a relationship with someone who listens to you and is genuinely vested in you being successful, you being healthy, spend your money someplace else. This also puts the onus of your healthcare on you. So I think that when I think about my patients and they come and they talk to me, they say that nobody has listened to them. And I think that's crucial. I think that you have to bear in mind that however old you are, you have had that body and know how that body works for however many years God has allowed you to live on the face of the earth.
And no one's going to know better than you. No one's going to know better than you.
Right. You are your own healthcare advocate. You got this on lock. If you go see somebody and you are trying to talk to them about what you're experiencing and they listen to what it is you say, go ahead and pick up and walk right on out the door. Take your money and your insurance card with you, because you wouldn't take bad customer service at a restaurant.
Nope.
You wouldn't take bad customer service in a product that you purchased.
Nope.
So why would you take it with your healthcare, which is more important and lasting than a purse that you're going to buy or a meal that you're going to eat and pass on through?
I love it. Anila, please tell the Muslim community, like, how can they find you, right? Because I know some people are probably energized right now, and I kind of alluded to your Facebook, like, give them all the dirt, because I need people to be able to kind of track you down.
Sure. So on the sly, I'm a firm believer that food is medicine that tells the body what to do. And so I have invested in becoming a health coach. So in addition to being an OBGYN, I'm a health coach. And with that said, I love answering questions, as Dr. Barry has alluded to. So on Wednesday evening, 7 p.m. CST, because I'm in Texas, I do Facebook Live on women's health topics. So you can find me across all social media at Dr. Anila OBGYN. That's Dr. Anila OBGYN. You can also find more information on my website, which is also www.dranilaobgyn.com. That's DRANILA OBGYN.com. And if you tune into any of my lives, you'll find that I love answering questions. I think that, as I alluded to earlier, My mom died because there was nobody there to advocate for her. And at 22 years old, I didn't know the questions to ask. My goal as a health provider is to make it so that you know what I know, so you're armed to take better care of yourself.
Woo! I love it. Absolutely love it. And of course, Lunch Learning community, like always, if you're running out, you're in the car, you're driving, wherever you're doing, you don't have to worry. All of her information will be in the show notes. So we will make sure, and you really just gotta watch one of her Facebook lives because she gets very animated, right? Like she will really make you like, oh, okay, yeah, this woman's health really is. That's why I said, you're gonna be on my show because I need someone animated to educate me on women's health, to really educate y'all. So again, she is all what she seems to be when you're listening to her, and you could just tell the love that's there, right? Like that's out of everything, right? You could just tell the love that is there to educate, to help you, right, get to where you need to be, and that's what I love about her, right? She's absolutely amazing. Again, we're gonna make sure she will be a repeat regular on this show, especially again, y'all ask me a lot about women's health stuff, and I'd be like, hey, this I know what I know, and I know what I don't know, and once I realize I know what I don't know, that's when I get the consult.
Well, sir, it has been my privilege, and it would most assuredly be my pleasure for wherever it is you'd like for me to talk about from Vagina Land, because I have that on lock. I would happily provide that for you.
All right. Again, appreciate everything that you do for your community. Appreciate everything you do for just the world, and allowing you to take your amazing talents outside of the clinic and outside of the one-on-one and being able to talk to the masses. So again, thank you, Dr. Anila, for coming on the show this week.
Thank you so very much, Dr. Barry. I appreciate it.
Thank you for getting to the end of the show. I am your host, Dr. Barry Pierre, host of the Lunch Learn with Dr. Barry, and this is another amazing episode that we like to bring to you week after week on betterment of empowering yourself for better health today. If you have not had a chance, please go ahead and subscribe to the show. If this is your first time listening, if you already listen and you've already subscribed, make sure to leave me a 5-star review because your support is absolutely important in keeping the show moving as it is. And if you have not had a chance and you want to check out today's show notes, always head over to lunchlearnpod.com. That is lunchlearnpod, all in one word, .com, and you can get the access to my show notes for every single episode, but especially the one you just listened to. And I'm going to see you guys next week. You guys be blessed. Bye.